Assalamu alaikum, everyone. I'm Dr. Nida Anwar. A very warm welcome to all of you in the practice-changing updates in hematology. It's my pleasure to moderate this first session, which is leukemia, AML, and MDS. And I would like to call upon my worthy chair and panelist. So the chair for our session is Dr. Tariq Mahmood Satti from Shifa International, Islamabad. So please grace the stage. Thank you very much. Our another panelist here is Dr. Qamar Nisa Chaudhry from Pathwel, Rawalpindi. Madam, please grace the stage. We have very renowned expert panelists who are connected online for this session. Dr. Farrukh Ali Khan from Dow University, Karachi. Dr. Irum Khan from Northwestern University, Illinois. Dr. Nadia Sajid from Inmol, Lahore. Dr. Salman Fazal from Allegheny Healthcare Network, Pennsylvania. And Dr. Talha Badar from Mayo Clinic, Jacksonville. So our first distinguished speaker for today's session is Dr. Jen Bewersdorf. Dr. Jen is Assistant Professor of Medicine and Hematology. His research and clinical practice interests include myelodysplastic syndromes, myeloproliferative neoplasms, and AML. And today, Dr. Jen would enlighten us about on how I sequence treatment in MDS. Can we have the presentation?
Good afternoon, everyone. My name is Jan Philip Bewersdorf from Yale University, and I would like to extend my gratitude to the organizers for the kind invitation to speak at this meeting on the sequencing of novel therapies in myelodysplastic syndromes. Before I get started with updates on novel therapies in MDS, I wanted to briefly highlight a few additional recent developments that are important for the practicing hematologist. First, the WHO and the International Consensus Classification published new definitions and diagnostic criteria for myeloid malignancies, including MDS. While both are largely aligned and highlight the importance of genetic disease characteristics, there are some key differences, such as the creation of an MDS-AML overlap category for patients with 10 to 19% blast in the ICC, but not WHO. Bone marrow biopsy reports might report both classifications, which might lead to confusion. However, there are ongoing efforts to harmonize those two classification schemes. Secondly, risk stratification for MDS has been based on the International Prognostic Scoring System, or IPSS, and its revised version, the IPSSR. In 2022, an updated version, the molecular IPSSM, was published along with an online calculator that's quite user-friendly. However, it is important to emphasize that clinical decision-making and clinical trial eligibility is still largely based on the IPSS and IPSSR, and that the IPSSM requires additional validation. Third, the response criteria for a higher-risk MDS patient have recently been revised, which is probably more applicable to clinical trials than routine clinical practice at this point. However, none of these recent developments shown on this slide is the main focus of my talk today, and I would now like to transition to the clinical updates. I want to start with a case to illustrate some of the current management questions in the treatment of patients with lower risk myelodysplastic syndromes. This is a case of a 74-year-old man with macrocytic anemia. A bone marrow biopsy and aspirate were performed in 2017 and showed mild erythropoiesis and mild megakaryocytic atypia. Given that the cytopenias were mild, no treatment was recommended. However, then over the next 2 years, he developed worsening leukopenia. A repeat bone marrow biopsy was performed, which showed MDS with multilineage dysplasia. There were no ring sideroblasts, cytogenetics were essentially normal, and NGS showed an ASXL1 mutation. The serum EPO level at this point was 139. So How should he be treated? This is the current approach to the management of myelodysplastic syndrome as outlined by the National Comprehensive Cancer Center Network, or NCCN guidelines. For the first part of this talk, I would like to focus on treatment of lower-risk MDS. And really the first distinctions we hear the presence of a deletion 5q, or in which case we would use lenalidomide versus non-del 5q. And there's been recent development here for a treatment of anemia. And over the next couple of slides, we'll talk about those. So first up, I would like to discuss luspatercept. Until recently, erythropoiesis-stimulating agents have been used in a first-line treatment for anemia in MDS patients. However, responses are often transient and not universal. And that led then to the development of luspatercept, which is an activin receptor type 2A ligand trap that inhibits myelosuppressive effects of TGF-beta signaling and thereby promotes erythroid maturation. In early phase clinical trials, it was observed that patients with ring sideroblasts and SF3B1 mutations have higher response rates to luspatercept. In a randomized phase 3 medalist trial, we see transfusion-dependent lower-risk MDS patients with at least 15% ring sideroblasts or more than 5% ring sideroblasts with an SF3B1 mutation were randomized to luspatercept or placebo. And as you can see here, luspatercept led to statistically significantly higher rates of RBC transfusion independence than placebo, leading to the FDA approval in the second-line setting. So if luspatercept works in the ESA refractory setting, the next step was to explore its efficacy in ESA-naive patients. To address this question, the COMMANDS trial was conducted and recently published in The Lancet. In essence, this was a randomized, open-label phase 3 trial that randomized ESA-naive, red blood cell transfusion-dependent lower-risk MDS patients to either erythropoietin alpha or luspatercept. The primary endpoint of this trial was RBC transfusion independence for at least 12 weeks. This slide shows you the baseline patient characteristics of the enrolled patients. As you would expect in this population, we saw an enrichment for patients with ring sideroblasts and SF3B1 mutation, maybe even more so than we would see in routine clinical practice, although this is certainly the most common subtype of lower-risk MDS patients. Importantly, most patients had a low serum EPO level and would be expected to respond to ESA. The study met its primary endpoint of RBC transfusion independence for at least 12 weeks, with a concurrent increase in mean hemoglobin level by at least 1.5 grams. And it was in generally more favorable outcomes in luspatercept arm, as you can see here. Additionally, luspatercept was superior to EPO, independent of baseline serum EPO level, RBC transfusion burden, and in subgroup analysis, patients with ring sideroblasts and SF3B1 mutations appear to benefit the most from luspatercept. Finally, the median duration of response was longer among patients treated with luspatercept versus erythropoietin alpha, with median duration of response of well over 2 years in luspatercept arm. This slide shows the safety profile, and in general, the COMMANDS trial confirmed what was seen in prior studies of luspatercept. There were only very few higher grade toxicities, which is an important consideration in this often older and frailer patient population. And so based on this study, luspatercept also got FDA approval in frontline setting. Another major development in the treatment of lower-risk MDS is imetelstat. Imetelstat is a telomerase inhibitor. What are telomerases? Well, malignant cells, including MDS cells, are frequently characterized by increased telomerase activity, which is an important mechanism to enhance the replication potential of malignant cells. Imetelstat binds to telomerase and acts as a competitive inhibitor with preferential targeting of the malignant clones, which enables recovery of normal hematopoiesis. Following encouraging data from early phase trials, the eMERGE trial was conducted and recently published, also in The Lancet. This trial enrolled lower-risk MDS patients who were red blood cell transfusion dependent and refractory to ESA or unlikely to respond because of a high baseline serum EPO level. Patients were then randomized in a 2-to-1 ratio to either imetelstat or placebo. And the primary endpoint of this study was red blood cell transfusion independence for at least 8 weeks. This slide shows the baseline patient characteristics. Similar to the COMMANDS trial, most patients had ring sideroblasts, and the median transfusion burden was quite high at 6 units over an 8-week period. Around 90% of patients had previously been treated with ESA. So this is quite an advanced second-line treatment population. And what was then seen in terms of the primary outcome is depicted here on the slide. The RBC transfusion independence with imetelstat, shown in pink, was higher than what was seen with placebo, here shown in blue. As you can see, imetelstat yields higher rates of RBC transfusion independence, which was also sustained over extended periods of time. Based on these results, imetelstat was approved by the US FDA for treatment of ESA refractory anemia and MDS. Other notable secondary endpoints in this trial were the impressive increase in median hemoglobin of 3.6 grams per deciliter in patients treated with imetelstat. Additionally, imetelstat was superior across multiple subgroups, including ring sideroblast status, baseline transfusion burden, and EPO level. However, it is important to keep in mind that imetelstat can have significant hematologic adverse events that frequently require dose adjustments, especially for thrombocytopenia and neutropenia, which can be a higher grade in some patients. The last point I want to highlight about imetelstat is the fact that it can reduce the mutation burden of driver mutations, including SF3B1, TET2, and DNMT3A, which suggests a direct effect on the malignant clone. The last agent I would like to discuss for the management of anemia and low-risk MDS is the HIF-alpha inhibitor roxadustat. HIF is a transcription factor that is involved with the body's response to hypoxemia and stimulates erythropoiesis under hypoxic conditions. Roxadustat has been shown to improve anemia in patients with advanced kidney disease and was evaluated in a randomized placebo-controlled phase 3 Matterhorn trial for the treatment of MDS. This slide shows the key eligibility criteria of the Matterhorn trial. One aspect I would like to highlight is the inclusion of patients with low transfusion burden, as low as 1 unit over 8 weeks at baseline. This slide shows the primary endpoint. A greater percentage of patients in the roxadustat arm, 47.5% specifically, compared with placebo at 33.3%, were transfusion independent for more than 56 days within the first 28 weeks. However, this difference did not reach statistical significance, so ultimately this is a negative trial. The percentage of patients who achieved transfusion independence for more than 112 consecutive days was also very similar in both arms. And so again, supporting that in this trial, roxadustat did not improve outcomes compared to placebo. So with this, I would like to summarize updates to treatment of lower-risk MDS. There have been exciting developments in the management of anemia and lower-risk MDS. At this point, erythropoiesis-stimulating agents can be a first-line treatment for anemia and MDS patients. However, luspatercept, based on the results from the COMMANDS trial, is moving clearly into the frontline setting for patients with ring sideroblast and SF3B1 mutations. And there's still more debate in patients without SF3B1 mutations and without ring sideroblast, where ESA remains a viable option. For patients with ESA refractory disease or high serum EPO levels, luspatercept is already approved in a subset of patients with ring sideroblast and SF3B1 mutations. In other patients, imetelstat can be an effective option and seems to be effective independent of ring sideroblast status. Roxadustat had a negative trial, which might be related to some trial design issues, but is not developed further in MDS at this point. Interesting question in the field obviously remain the optimal sequencing of agents, as well as any potential of disease modification and long-term follow-up data. So for the remainder of the talk, I would like to focus on updates in the management of patients with higher-risk MDS. While the treatment of lower-risk MDS patients is primarily palliation of symptoms related to cytopenias, treatment of high-risk MDS ideally tries to prolong life and delay transformation to AML. Before discussing novel agents, I think it is important to remind ourselves where we currently are and where we came from. So this is the AZA-001 trial that compared azacitidine to conventional care and showed a statistically significant overall survival benefit for azacitidine. Based on the study, azacitidine has been approved for MDS and remains the standard of care for well over a decade now. However, long-term outcomes with azacitidine monotherapy show that 5-year overall survival rates are generally less than 10%, and novel treatment options are needed. The combination of hypomethylating agents with venetoclax has really revolutionized the treatment of older patients with AML. At the ASH 2023 meeting, we saw an update from the ongoing phase 1b study of azacitidine with venetoclax in treatment-naive high-risk MDS patients. The study schema and key eligibility criteria are shown in this slide, and the primary endpoint was complete response rate per the IWG 2006 criteria, with several key secondary endpoints as shown on this slide. And I think it's important to highlight here for MDS patients that venetoclax is generally used on days 1 through 14 of a 28-day cycle, which is different from what we use usually in AML. This slide shows the results of the primary endpoint of CR and overall response rate. And as you can see, the CR rate was 30% with a median duration of CR of 16.6 months at this data cutoff. Responses also occurred early in treatment with a median time to CR of 2.8 months, although the delayed responses were also observed in a subset of patients. However, it is also important to note that the majority of responses were marrow CRs, which was accompanied by hematologic improvement in only a subset of patients. While these results are encouraging, we'll have to wait for the publication of the results of the ongoing randomized phase 3 Verona trial of AZA venetoclax versus AZA placebo before we can really adopt this as a standard of care. Another randomized HMA combination trial was published earlier this year. In this trial, the anti-TIM3 antibody sabatolimab was added to hypomethylating agents, and 127 patients with HMA-naive MDS were enrolled. The overall response rate and CR rate were similar in both groups, as you can see here. And at the final analysis, median progression-free survival was 11.1 months in the sabatolimab group versus 8.5 months in the placebo group, which was not statistically significant. So again, another negative trial of HMA combinations. Despite multiple negative HMA combination trials in MDS, in recent years, there was one new FDA approval in MDS, namely of the IDH1 inhibitor, ivosidenib. And although it's important to emphasize that IDH1 mutations in MDS are rare, occurring only in 3% of patients, the efficacy of ivosidenib in a relapsed refractory MDS population was very impressive, although it was a small trial, with an overall response rate of 83% and a CR rate of 39%. And responses were also very durable, and the median overall survival was 36 months, which clearly exceeds historical standards of HMA refractory patients. Finally, ivosidenib was very well tolerated, highlighting the importance of really performing genetic testing, ideally on all patients with higher risk MDS, to identify the small number of patients who can potentially benefit from targeted therapies. Finally, I would like to reemphasize the importance of transplant in MDS, as allotransplant remains the only potentially curative therapeutic modality in MDS. In this trial, 384 patients with high-risk MDS were evaluated for transplant, and patients who had a donor and underwent transplant had a better 3-year overall survival compared with patients who did not undergo a transplant, as you can see here. And there also might be a plateau in the survival curves, although longer follow-up is necessary. An unresolved question in the field remains whether cytoreduction with HMA prior to transplant is necessary. However, in my opinion, not all patients with high-risk MDS need treatment prior to transplant, especially if the blast count is low and if transplant can be arranged in a timely manner. Another question and area of significant debate is TP53 mutations and if those patients should really proceed to transplant or if the outcomes are dismal anyway. So post-hoc analysis from the trial I just discussed demonstrate that the outcomes of TP53 mutant MDS even after transplant remain poor, and that there's no difference in both overall survival and relapse and progression-free survival rate between single and multi-head TP53 mutation status, and both doing worse compared to the TP53 wild-type patient. Nonetheless, I do offer allotransplant to high-risk MDS patients independent of their TP53 mutation status, as transplant remains the only potential curative therapy, and it does offer a survival benefit over no transplant, as you can see here, with a statistically significant difference, although long-term survival with transplant for TP53 mutant MDS is only around 20 to maybe 30%. And lastly, an interesting study from Italy showed that time to transplant is an important factor for overall survival. In the study of over 7,000 MDS patients from Europe and the United States, patients with high-risk MDS benefited from an earlier transplant strategy, which means within the first 3 to 6 months, while patients with lower-risk MDS could safely delay transplant. So, in summary, the treatment landscape of higher-risk MDS has remained largely unchanged, and that's why clinical trial enrollment should always be prioritized, and something I do in my practice. Outside of clinical trial, HMA monotherapy remains the standard of care. However, this might change with the results of the ongoing phase 3 Verona trial of azacitidine and venetoclax. Sometimes I do use aza and venetoclax off-label in MDS, especially if the blast count is bordering AML and the patient is a transplant candidate, because I do think it is more effective at rapid cytoreduction, but this should then be consolidated with a transplant afterwards. Independent of upfront treatment, early allotransplant is important and has been shown to improve outcomes. So any treatment before transplant should not delay proceeding to transplant, in my opinion. With this, I would like to end my presentation. Thank you very much for your attention. I'm looking forward to the panel discussion. Thank you.
Thank you so much, Dr. Jan Bewersdorf. Our second distinguished and well-known speaker is Dr. Talha Badar. Dr. Talha Badar, clinical and research interests include acute leukemia, myeloid disorders, and cellular therapy. Dr. Talha Badar is from the Mayo Clinic, Jacksonville, and today he's going to enlighten us about hematopoietic stem cell transplants for AML in 2024. Dr. Talha.
Hello, everyone. I'm Talha Badar from Mayo Clinic, Florida, and today I'll be discussing about sequencing of therapies for acute myeloid leukemia in the contemporary era. These are the learning objectives. We'll discuss how to utilize genomic data in sequencing therapies and making treatment decisions for acute myeloid leukemia. We'll discuss about significance of MRD testing in making treatment decisions regarding consolidation therapies. We'll also discuss how to utilize allogeneic hematopoietic stem cell transplant to improve long-term outcome, and what are the unmet needs or unsolved issues in the management of AML in the modern era. So the background, understanding of pathobiology of leukemia has led to identification of therapeutic targets and development of novel therapies. More importantly, highly sensitive monitoring techniques have led to more precise treatment decisions and ability to sequence therapies effectively. This is the slide showing the approval of drugs for management of AML from 2017 till to date, starting from approval of first FLT3 inhibitor based on randomized trial for the management of AML with FLT3 mutation, followed by approval of liposomal daunorubicin plus cytarabine combination, CPX351 for patients with triplet AML or secondary AML, then IDH1/2 inhibitors, clasdigib, BCL2 inhibitors, which has been the paradigm shift for management of AML, especially in elderly who are ineligible to receive intensive chemotherapy. Most recently, approval of more potent FLT3 inhibitors, as well as oral decitabine in combination with cedazuridine, which improves the bioavailability and make it comparable to injectable decitabine, and then a second generation or more potent IDH1 inhibitors. This all has led to improvement in outcomes of acute myeloid leukemia, more importantly in young individuals who are able to receive intensive chemotherapy, and these individuals are more likely to have a favorable risk phenotype compared to older individuals where patients are more enriched with secondary AML and therapy-related disease. In that group of patients, we haven't seen any much improvement in outcome over several decades, with median survival ranging between 12 to 14 months off trial and on trial. So, risk stratification in AML. Generally, we use two classification systems in our everyday practice. Most of us follow the NCCN guidelines. We divide patients based on molecular aberrations into better risk, intermediate risk, and poor risk disease. The better risk are those with core binding factor leukemias or those with MP1 mutation with absence of FLT3 ITD mutation. A poor risk are those with complex cytogenetics, monosomal karyotype, 11q23, inversion 3, and so forth. There are certain molecular aberrations which are mentioned here, also associated with dismal outcome. More importantly, AML with PIK3 mutation, those with splicing factor mutations, and those with BCOR, EVH2, and other mutation as mentioned here. The ELN 2022 classification, more or less comparable to NCCN classification in terms of dividing patients into favorable, intermediate risk, poor risk disease, with not much to differentiate between the two. So when it comes to therapy decisions, broadly, patients can be divided into intensive eligible and intensive non-eligible. Then these patients can further divide into, based on cytogenetic and molecular aberrations, into favorable, intermediate, and poor risk disease. More importantly, which is clinically more meaningful, I've separated the P53 mutated AML in a distinct category because these patients continues to have a dismal outcome with conventional all novel therapy combinations and should be treated or looked at differently with a different perspective, and treatment should be based on individualized patient profile. So we'll talk about AML induction strategy. So AML induction strategy among individuals who are eligible to receive intensive induction based on their molecular risk are classified as is shown here into favorable, intermediate, and poor risk disease. Favorable risk AML who are eligible to receive intensive chemotherapy are treated with intensive chemotherapy combination with gemcitabine and vancomycin, which has shown to improve relapse-free survival. And poor risk disease, we have several options to treat them either with ven-based combination or liposomal combination of daunorubicin plus ARC, CPX351 in patients who have secondary AML or therapeutic disease. Patients who have PIK3 mutated AML, clinical trial participation is still encouraged in a very small subset of patients based on several analyses suggest that a small subset of patients can benefit from venetoclax-based combination provided that they receive adequate consolidation therapy in terms of bone marrow transplant to improve their long-term outcome. For intensive ineligible patients, overall, venetoclax HMA-based therapy, as you can see here, is the preferred regimen. Apart from certain circumstances, Among those with IDH1 mutation, we have an option to treat these patients with Videsa plus Evacitinib combination or Videsa plus venetoclax combination. When I say Videsa, I mean azacitidine. Those with poor risk disease, with secondary AML or therapeutic disease, randomized controlled trial has shown that CPX351 is tolerated even up to 75 years of age, and certain subset of patients who have good performance status can pursue with bone marrow transplant to improve their long-term outcome. So what are the unmet needs or unsolved issues in terms of induction strategy for newly diagnosed AML? I would say the most burning issue is the how to treat patients with PSN-related AML or 17p deletion. Second issue, which is growing attention, is the duration of venetoclax-based therapy. As we've seen that continuous dose of venetoclax is more toxic, especially in elderly AML population with delayed count recovery, myelosuppression, and increased risk of infection. And thirdly, most of the centers for high-risk group, even patients who are eligible to receive intensive chemotherapy, are treated with ven-based combination or HMA-based combination or on a clinical trial, considering they don't respond as well as to intensive chemotherapy regimen. So we'll briefly discuss about duration of venetoclax. Although at current point in time, the standard of care is to give venetoclax continuously with azacitidine for 7 days monthly. However, clinically we have seen continuous ven exposure lead to prolonged myelosuppression and toxicity. The retrospective study, which was presented a couple of years ago at American Society of Hematology meeting, in which they utilized the 7+7 regimen, 7 days of azacitidine and 7 days of venetoclax monthly in elderly AML patients who are ineligible for intensive chemotherapy. The results are impressive, although achievement of complete remission took longer compared to the standard of care dosing schedule of venetoclax. However, after cycle 2, comparable portion of patients achieve CR/CRi, as you can see here, translating into median overall survival at close to 1 year or so. This led to debate that elderly frail patients may get benefit without impairing the quality of life with 7+7 regimen. Secondly, at Mayo Clinic, we did retrospective analysis on a cohort of more than 300 patients, in which we evaluate the difference in outcome between 14 days versus 21 days or 28 days regimen. As you can see from the Kaplan-Meier curve here, there's hardly any difference in terms of outcome. However, on a multivariate analysis, patients who have ELN adverse risk phenotype did get benefit of when given from more than 14 days per cycle. So to summarize this, patients who may be frail or may not tolerate continuous ven exposure, or countries where restricted resources or where the patients are paying out of pocket, a 7-day ven-based regimen or a 14 days ven-based regimen can achieve a comparable and meaningful response and outcome. Then, how should we manage FLT3 mutated AML patients who are ineligible for intensive chemotherapy regimen? Currently, as per guidelines, venetoclax plus hypomethylating agent is still a preferred regimen. However, there are some studies incorporating FLT3 with HMA or FLT3 with venetoclax plus HMA combination. When I say HMA, I mean hypomethylating agent, either azacitidine or decitabine. Among them, this is a study, phase 1b study, where a triplet combination with gilteritinib, venetoclax and HMA was used as an upfront, or in a relapsed refractory AML patients who are ineligible to receive intensive chemotherapy. As you can see here, with subsequent therapies, their high rate of clearance of FLT3 ITD mutation by sensitive techniques, and that has translated into improved survival At the follow-up reported in this published trial, the 18 months relapse-free survival and overall survival was close to more than 70%. However, the adverse event, if you look at here, significant proportion of patients required dose reduction and had infectious complications second to myelosuppression. So a triplet combination is promising, but better dosing schedule is required to counter the myelosuppressive element of this triplet therapy in elderly AML patients. How to treat P53-mutated AML patients? As you're aware, there's several novel therapies have been evaluated, which has shown initial promising results, but later on randomized data didn't show any benefit in improving outcome. So it has continues to be a challenge. P53 is a guardian of genome, and various stresses can lead to mutation, which leads to several cancers, including leukemia. Several novel therapies have been evaluated alone or in combination, failed to show any improvement in outcome. Real-world analysis, several have shown that either intensive or non-intensive chemotherapy regimen continues to show a modest response and very dismal outcome with the survival in the range of 6 to 8 months. However, in a subset of patients who can bridge to bone marrow transplant can have a meaningful long-term outcome. In one of the analyses which we did in collaboration with several centers, we couldn't see a benefit of maintenance therapy post-transplant among individuals with P53 mutation who received transplant or the condition intensity. However, patients who maintain remission at day 100 post-transplant or develop a chronic graft-versus-host disease shows to enjoy a most benefit out of it. Then, for adverse AML, as I mentioned earlier, there's one retrospective analysis that suggests that Ven plus HMA combination may be comparable to intensive induction after multiple imputation, as you can see on the survival curves at the bottom. That makes you think that for adverse AML, intensive chemotherapy may not be an option. There are prospective studies ongoing to answer this particular question. So AML consolidation strategy, we go back to the diagram. The consolidation strategy, I think, should be based on the depth of response with induction across the board, assessing the measurable disease with most sensitive technique, and making call for consolidation strategies, a chemotherapy, maintenance therapy, or a bone marrow transplant. So as we have divided patients for induction strategy into risk group, then consolidation strategy also continue to follow that sequence where favorable risk AML are benefit from consolidation therapy comparable to bone marrow transplant provided they achieve MRD negativity with sensitive technique, whereas those with poor risk AML and eligible for bone marrow transplant do benefit from allogeneic stem cell transplant to improve their long-term outcome. Patients who are intensive ineligible and high-risk disease, certain subset of patients can be bridged to bone marrow transplant to improve their long-term outcome, especially with current supportive care and GVHD prophylaxis. That continues to show improvement in tolerability of this approach in older AML patients. So what are the unsettled issues regarding consolidation for AML and CR1? I think the duration of Ven plus HMA is the most burning question. How long should we continue in patients who maintain a good response on the therapy? Then the question about maintenance therapy post allogeneic stem cell transplant. The data is heterogeneous and especially in marker agnostic AML patients.
Thank you very much, Dr. Talha. Our next distinguished speaker is Dr. Shahrukh Hashmi. Dr. Shahrukh Hashmi is Professor of Medicine, Director of Research Development, and Senior Associate Consultant at Sheikh, Shakbout Medical City, UAE. His research interests include cancer survivorship and bone marrow transplant. Today, Dr. Shahrukh will speak about challenges and promises of developing CAR T cell therapy in Pakistan. Dr. Shahrukh.
Assalamu alaikum. It's a great pleasure to be here virtually at least, and sorry I couldn't be in person. I'm going to talk about challenges and promises of developing the CAR T-cell therapy program in Pakistan. There's a lot of abbreviations that I'm going to use throughout this presentation, and I'm not going to expand on some of them, so it's important for us to understand those now as we're beginning to get into the cell therapy. The CGT is a very common terminology that's used in the US mainly. It's cell and gene therapy. And the counterpart of that is ATMPs in the European Union. That's Advanced Therapy Medicine Product. In between, there's gene therapy for GT. As you know, the history of the gene therapy, this is back in Penn, a long time ago. Jim Wilson, who started the program, that was adenovirus at that time for metabolic inherited diseases. It went to adeno-associated virus as AAV, as given here, and then lentiviruses came in as well afterwards. And we've got the L and P terminology, that's lipid nanoparticle. As you well know, Drew Weissman won the Nobel Prize last year for the discovery of the particles which will really help with the vaccine development for COVID-19. And LNP is very highly refined by Carl June and Drew Weissman at Penn in Philadelphia. The CAR T cells for chimeric antigen receptor T cell, obviously the CAR NK cell terminology is used for the NK, but we also call NK CARs in some regions. Now, CMC is very important. And I highly encourage all of you to look into the drug development programs, which is either small molecules or biologics. And the chemistry manufacturing controls is a critical process that we must know when we enter this field of a new era of cell and gene therapy. CGMP is typically the standards of a facility that will be dealing with quality standard drugs or CAR T cells or gene therapies or other products. And the GLPs for good laboratory practices. And these all are important, actually. As all of you rightly know, the CGT, the cell and gene therapy market, continues to increase all over the world. And as you can see, the growth rate of the CAGRs, which is an economic term mainly, will continue to increase much more than 10%. In fact, it's up to 50% over the next few years. And as you can see, the therapeutics are different areas, which may include or may not include gene modification. That's gene editing. And that process has increased over time because of the CRISPR-Cas9 editing, but now with the base editing and the prime editing as well. Now, when we talk about Pakistan and similar countries in which we want to start a program in cell and gene therapy, you want to really work towards an ideal state. Because if we don't plan, then we will never get it. But what's necessary to start is something I'm going to show you in a little bit. But I can tell you, even with extremely limited resources, this quotation, which is centuries old, still plays a big role. When there is a will, there is a way. Others did it with very limited resources, so Pakistan can do it too. Unification is there, and it's necessary, but there's other things as well that are absolute requirements. But when the mindset is that we've got to do it for the sake of the countrymen's sake of the patients, and so many patients need CAR T cells and gene therapies, and we've got to find a way. There's no ideal way ever. Now, the way clinicians look into this is very different compared to the regulators and compared to the industry. All three are important parts, right? And I presume most of the current audience of this conference are clinicians, hematologists and nurses and pharmacists who are dealing with hematological problems. The industry meetings are similar. They're thousands and thousands of people, like the Bio meeting, which happens every year in San Diego or Boston. There's called the Biotech International Convention. And a lot of people get together, the pharmaceuticals, biotech companies, industry leaders, investors, venture capitalists. And they discuss exactly the same thing, but from a different angle. And the regulators get together as well. There's the regulators in the US, FDA, MHRA in England, EMA in Europe, PMD in Japan, TG in Australia, NMP in China, and many, many other countries. I can name many of those. And Department of Health, where I work in Abu Dhabi in United Arab Emirates. That's important, what I just showed you, but let's look into the other path, how regulators are looking into it, and what is real life anyways, that any physician who wants a CAR T, who invents a new CAR T cells or CAR NK, or a new target or new CD19 plus CD22 plus another antigen that they're targeting, you got to interact with the FDA first, or the regulatory agencies in your country first, to make sure that you get the IND. You have the pre-IND discussions, then you get the IND designation, this investigation new drug, which is basically telling you that you can now start the human clinical trials. This pathway is not for researchers only. This pathway is implemented for decades in the academic centers who are doing research in the US and now in private practice as well, because everybody wants to do clinical trials. You've got to have the IND first to do the phase in human trial or the phase 1 trial. Well, in between this box of RMAT, which is the RMAT designation for the advanced therapies, and the next one, which is BLA for fast breakthrough designation, there's another 5 years at least, or another 3 years, if not 5 years or more. And that's another $100 million to $500 million to $1 billion typically, which is phase 1, 2, and 3 clinical trials. If you combine all of those, it's pretty expensive. And you file for the BLA, that's biological license, and then the approval comes. And then another cycle starts, manufacturing, CMC, supply chain, cold chains, ultra cold chains. It's a very sophisticated procedure, and it's not that easy actually. Typically, drug development cost from drug development chemistry to preclinical studies to phase 1, 2, 3 approvals, manufacturing, and supply chain. It's about $2.1 billion according to Deloitte survey. But in the cell and gene therapy, the chances of success are much higher, so you don't count too many failures. The $2.1 billion US dollars includes a failure rate of a drug development. Now, let's change gears and think about the hospital facilities part. One cannot start the CAR T cells gene therapy immediately because you've got a pathology lab and you've got a pharmacy and a ward with a positive pressure room. It doesn't happen that way. The first is our stepwise approach. We're going to start with a closed system, which is an automated system to generate CAR T cells in-house in the facility, which is point of care, in-house generation of CARs. And if that's the goal, then you don't need a full GMP facility, which is accredited or licensed. You need actually just the clean rooms. Today, in 15 minutes, there's no way I'm going to go over the clean B and C and D rooms, but in fact, when we inspect facilities, we go over details when we're looking at accreditation and standards of the facilities. But suffice to say, it's a sophisticated process for the facility part, the space for the lab, which has anterooms, rooms. It has a very sophisticated HVAC system, which is the ventilation systems, not just positive pressure HIPAA rooms, but we're talking about the lab, where you're going to put the closed system. Well, if it's an open system, then we're talking about a different facility, either to receive external product or to manufacture. Well, you start a CAR T program in any country, you don't want to have a cGMP facility to manufacture from scratch the ex vivo therapies. You don't want to do that. The closed systems is what most of the countries with limited resources are requiring. On the left is a Cocoon system from the Lonza pharmaceutical biotech company, and on the right is the Prodigy machine from Miltenyi. You can have electroporators to use any kind of vectors in any of those. Suffice to say that this is the tip of the iceberg, and there's many more companies which are developing systems. The GMP rooms, let's not go into the details, the clean B and clean C rooms, or the clean D, which is required for certain processes. You need advice actually exactly if it's a semi-automated system from, for example, China or Russia or other countries, then what kind of room and facility you would need in order to comply with the standards. But GMP-like ISO room may suffice for the closed system. This is an example by my friend Sayyid Osman Ahmed, who actually published this from King Faisal in Riyadh. This is a typical setup of the CGMP-like room for the Prodigy. I highly encourage all of you to look into, if you want to look into one document to start to understand the bigger picture of what is necessary, then look into the IEC requirements of the FACT and JC, which are similar. This is a FACT document from the FACT website, and it has many chapters just below if you go down on the page. But this will capture most of the essential information that you need to start a program. Now, the other things that a lot of people think at the end, and they should be thinking in the beginning, when you talk about ex vivo therapies, I mean, that you do the apheresis, then you're going to send the apheresis apheresed T cells to a facility internationally for the CAR T cells for approved product, which is commercially approved in the US FDA and now approved in Pakistan, for example. Then you need to think of the 4 airport trips as well, because it's going to go from one hospital to airport local in Pakistan, then to, for example, US or Belgium, Germany, Netherlands, for example, and come back. Not an easy process, because the world is not technologically and scientifically as advanced as we think they are. In the real world, at the customs, people may just block it, and they say, we've got a viral vector, oh my God, I mean, this is an infectious agent, and we have no idea about the virulent properties of this virus. In order to avoid all these problems and challenges, you got to plan ahead of time, actually, and talk with the airport facility directors and leaders and government. Make sure we got enough support for the customs, and obviously the shipping and the cargo industry is so important. This is part of the process. I mean, you got to train a lot of people, nurses, pharmacists, scientists. Neurologists, I can't even tell you, I mean, how important this is. And when we started the program in the Middle East, we had to train a lot of neurologists and the ICU docs for the ICONs and CRS respectively, because they need to know that inside out. You can't rely on hematologists 24/7, because hematologists, bone marrow transplant physicians, are not there in the ICU 24/7. They need to know CRS grade 4, how to prevent it as well and treat it. Payment systems must be clear. Leadership has to be buy-in. If the leadership is not in the favor of a cell therapy program, which requires a lot of investment in human resources and financially, then there's no point. You got to do a better job in having leader buy-in. This is what I deal with every day. I had discussions about the SG guide RNAs, novel capsids, the transduction efficiencies, but we're not going to go into the details of this today. But this is one thing I want to explain in detail, how things work with the IRBs of the government and how you actually get the product approved, because you need to do research. I can't even tell you how important the research is, because if you tell me that the gene therapy is $2 million or $3 million, which the tag price is in the US for certain of them, and nobody can afford, or very few people can afford that. Even more of a reason, right, to do a clinical trial so that the pharmaceutical company, Vertex, Bluebird Bio, others can provide the gene therapy and the CAR T for free, right? I mean, so in order to do that, how do you track the big pharma? You got to know the basics of research, but also you need to have a clinical research facility or clinical trials unit. But ex vivo and in vivo therapies are totally different, and we're developing many in vivo therapies now, because we know allogeneic CARs and in vivo therapies could be the future in many countries of the world. Because we have failed in the past more than 13 years since the first CAR T cell was given to Emily Whitehead to disseminate and globalize the innovation of CAR T cells, because less than a quarter of the world is using CAR T cells regularly, routinely, on commercial and clinical basis, which is amongst the 200 countries of the world. And less of the quarter is like 30 countries in the EU, for example. I'm just giving a ballpark figure. But if you include that, very few destinations on Earth have got routine use. But autologous CARs and allogeneic CARs, I mean, suffice to say that 7 CAR T cells that are approved by US FDA for clinical use or autologous CARs, and not the allogeneic CARs, but the allogeneic CAR T cells. Now the phase 3 trials are happening. Some of them are single-arm phase 2b trials, and we're going to see the results. So ideal state includes a clinical trials unit. That's something we need to invest in. We need a separate talk for this. What are the basics of clinical trials unit? Because unless you have a world-class clinical trials unit, no big pharma or big biotech will come. You're not going to get the agent for free. But that's the goal, right? I mean, you develop a research infrastructure innovation unit and a GMP in the future. But if you start working on the clinical trials unit now, you may be attracting Pfizer, Novartis, Janssen, BMS, and the gene therapy companies, Bluebird Bio and Vertex and others, to do the clinical trials, to actually develop a quorum of people who could do clinical trials. Because the clinical trials are getting more patients on the CAR-T program than the commercial program worldwide, if you include China as well. I mean, that's the reality that we got to know, that research comes first. But more patients, not in cardiology, not in hematology oncology, but in CAR world, more patients are actually receiving the CAR T cells on a properly conducted phase 1, 2, or 3 trial. So at the end, I want to mention that you should strive for the ideal. Start planning for that. You've got to convince the leadership of the institutions, of the government, to really think, for the sake of the people, thalassemia burden is too much. Leukemia, lymphoma, myeloma burden is too much. Genetic diseases burden is too much, for which the only treatment is either a bone marrow transplant or a gene therapy. We have to think of a clinical trials unit one day, a world-class unit which the pharmaceuticals will trust with their accreditations, international, so that they can come and say, okay, fine, we're going to do the trial here. And you can be leading that in the world before most of the developing countries of the world. I mean, that's doable. The point of care automated systems, semi-automated systems are the way to go initially for the CAR manufacturing. You don't need to build a vector facility. In fact, if you're here, some of you are going to faint the cost of a vector facility, of a world-class vector facility. I'm not going to go into BSL-3 or BSL-4 at the moment, but it's suffice to say it's not an easy thing to make a vector, Lenti and AAV both. We're shunning away from a lot of vectors, going to Sleeping Beauty, transposons, many other LNPs, of course, in the clinical trials by Ordina, Myeloid, Umoja, you name it. Many are starting. Caribou is doing very fancy clinical trials with gene editing. But you can import the vectors, suffice to say. Clinical trials should be considered early on. Prepare and train the team. At the end, I want to say that I want to end by saying, just do it. Get minimal resources, train people, really educate the people. Minimal program with the closed system, start at one place. Make sure you check the boxes for minimal requirements of FACT and go ahead with that. And strive for getting FACT accreditation within 3 to 5 years. With that, I want to thank you, and really, there's a group of people within Pakistan and outside Pakistan who want to help establish this for the sake of the country, but also for the sake of the patients that we've got. And with that, I want to thank everybody of you for listening to me, but I want to thank the patients who volunteer to be on the clinical trial for the sake of other people, when the consent clearly says that you're doing it with no benefit to you, you're doing it for the people who are coming after you. And there's many of us who are enrolled in clinical trials for any diseases. With that, thank you for having me. Appreciate it.
Thank you so very much, Dr. Shahrukh. Very insightful and thought-provoking. Just do it. Now the floor is open for the questions. Any questions for our speakers?
So we've had some very good talks today, and the first one was by Dr. Brewster from Yale, Connecticut, on sequencing treatment in myelodysplastic syndrome. And he talked about low-risk MDS, the role of ESAs, patients who are failing ESAs, or the comparison of ESAs with luspatercept, and the newer drugs, and the outcome of recent trials. So please.
The question is that in our patients...
Are they online to answer the questions?
Yes, we have. The speakers are online, right? They are not? All right.
The question is that some of the patients here are younger, maybe in third or fourth decades. Can we think of early bone marrow transplant in such patients, even if they are having the low risk disease because of the younger age? That's the question.
I would think that is, of course, a very intriguing and an excellent question, of course. Dr. Brewster did show a slide. He showed a slide at the end where the results of several trials showed that early transplant was beneficial. But of course, there is
For the high risk, yes.
But for higher risk and for low risk, I think, again, it's the balance, right? Whether you're going to get an advantage from transplant versus the morbidity and mortality of transplant, the TRM.
Sir,
Go on.
the speakers are not online, but recently I had gone through few data. So there is EBMT data to support that if you transplant patients early, the 5-year overall survival and disease-free survival is around 65 to 70%, which is significantly higher once we transplant the patient traditionally in MDS in high risk, which is around 40 to 43%. So high risk MDS transplant outcomes are around 40 to 45%, but once you transplant them early, the overall survival and PFS is significantly high. Especially in our population, once we do not have genetic testing, we do not have IPSS-M. So once IPSS-M was standardized, so they compared, so initially they stratified the patient into RISS and then IPSS-M. And they compared that once you apply IPSS-M to the same patient, around 1/3 of the patients are up-categorized. Like they were initially categorized as low risk, but the genetics were missed. Most of them were ASXL1, DNMT3, they were high risk. So in our setup, where we lack NGS data, and there is a very strong EBMT data to support early transplant. So my humble opinion is that for selected patient, like with early transfusion requirement or severe cytopenias, we should proceed to early transplant.
So
Even in low risk patient, if they are low risk on.
So the data that you just shared, the EBMT study, did it include low risk patients?
So it was, so what they did that they had an MDS registry. So from MDS registry, they segregated and separated low risk on the basis of IPSS and RIPSS, and they actually calculated transplant outcomes of only that data.
Okay.
So on that data, it was published by Professor Mufti et al. So the data showed significantly higher PFS and OS once you transplant them early. So especially once we do not have access to genetic testing and we are not likely to have it in the near future, and with lack of transfusion support, for selected high-risk patient, I think we should think of early transplant.
Perhaps something like patients who have multiple cytopenias, perhaps patients who have a high transfusion requirement, patients who are in a fairly good shape to undergo transplant. I think you could have some sort of stratification. Yes.
Yeah.
I would like to comment, madam, you're very right, and I endorse what Raheel said, because our stratification is not the way we see in the West. We don't incorporate IPSS-M, so the risk is not clear, we don't know. Having said that, in low risk patient, the patients who are young, because in our part of the world, transplant takes time. The search for the donor, the funds and all that. So it's better to find a potential donor, keep a very strict vigilance. If they are transfusion dependent, yes, proceed for the transplant. If they are not transfusion dependent, maintaining good quality of life and whatsoever, but at least have a potential donor. So once they become high risk or anything, so proceed for transplant as early as possible. It improves the outcome.
I would like to add to it. As you know, we do not have a registry for matched unrelated donor. So our donor is going to be an older donor for an older patient, and it's or haplo. So how will you, extrapolate the data for that?
So the median age in EBMT study was 58 years. So it was relatively higher. We normally think twice before transplanting MDS more than 50 years. So most of our MDS is actually middle-aged patients. And the donor are actually, we do find median age of so the data of our center, so which I showed in a conference, so we had transplanted 41 MDS at our center till 2024, and the median age was 30 years.
Okay, so that's because these are the patients who got to transplant. I think the question that you have is what you do with the older patient. Yeah, so I think if it's an older patient, so that's a difficult question again. Yeah.
Yeah, but actually, in Pakistan and in this part of the world, the MDS cases are relatively younger. It's my observation. But in the European world and all there, mostly the patients of MDS were above 50s, 55, 60, even more than that. And still they are doing the bone marrow transplant in these patients. A little bit compromised because as the more the age is, you can't go for the myeloablative conditioning. So they are tailoring it with sort of reduced intensity conditioning to prolong their life's expectation. Otherwise, but in long term, the results were not as in a younger patient if you go for the transplant, because you can have a full myeloablative conditioning and the results are also relatively good. The second thing about the Dr. Jain's presentation, in which he has shown the role of hypomethylating drugs, which can be given, both the Dr. Talha also been discussing venetoclax with the hypomethylating drugs, and but they are not sure how long you have to give the therapy, 6 courses, or you continue it for till the patient is surviving. And it's a costly affair in a country like Pakistan. It's very difficult to continue the hypomethylating with venetoclax, even tailoring it with the smaller doses. But it's still very, very difficult to manage these sort of patients for long period of time with these sort of drugs.
So I've got a couple of observations, comments on the presentations other than on MDS. So one was about the AML. So I was discussing yesterday with John Pervez that it's easier to be an expert on AML than anything else, because nothing has changed. Still 7 plus 3 is the standard. There are a few add-ons, but that is what forms the core of treatment, and still we have seen that 7 plus 3 is still their standard of care. So that's very interesting, because probably the highest number of patients who undergo treatment, high dose chemotherapy, and then of course the allogenic transplant in the whole world is in AML. So AML transplant on one side and rest of the transplant on the other side. That's how big is the number. And there's so much, with so much patients and so much research going on in AML, we still have got the 7 plus 3 as standard of care. That's one observation. And the other one is on MDS, the Jan presentation. I was just looking at the low risk MDS, luspatercept versus placebo. 40% luspatercept, placebo 12, 13, 16%. So luspatercept significantly better. But roxadustat, 47% response, but placebo did very well, 33%. So not significant. Thank you, Irum.
Thank you very much, sir. Thank you very much, all the speakers, panelists, seniors. My humble question is about AML in elderly. Recently, I treated 3 patients more than 65 years of age with Azavan, 6 cycles, followed by venetoclax maintenance, 15 days on and 15 days off. So my question is, in your experience, how long should it be continued? Should it be discontinued? Or how to go about it? It's been 3 years, 1 patient 3 years post Azavan, 6 cycles, and other 2 patients are more than a year.
Dr. Talha is online. Dr. Talha, would you like to answer this question?
So, yeah, so with all due respects, I humbly won't agree with the comment before that we haven't changed over the last decade or so for the management of AML. As I've shown you in my presentation, there are like 12 drugs approved for acute myeloid leukemia, including FLT3 inhibitors, IDH1, 2 inhibitors, and olutasidenib, as well as BCL2 inhibitors, and so forth, including oral decitabine. I totally acknowledge it's difficult to treat patients in AML in in Pakistan and so forth, where we are resource restricted, but things have changed. With the genomic data, we are able to individualize treatment. When it comes to venetoclax, duration of venetoclax therapy, as I've shown in my presentation, it has been several studies at retrospective and data from prospective trials suggesting that patients who have a genomic profile, including those with IDH1, IDH2, or NPM1 mutation, they tend to have a best outcome with venetoclax-based therapy. And there are a couple of trials that evaluated stopping treatment after 12 cycles among patients who achieve a deeper response can maintain a treatment-free remission for 60% of the time. Then there is another study from France where they've shown MRD negative patients can maintain a treatment-free remission for 80% of the time post 2 years. And they have also shown that patients who receive less than 5 cycles versus more than 5 cycles of Veneza, more than 5 cycles group tends to do better. In terms of stopping either venetoclax or HMA-based therapy, there was no difference in terms of stopping either venetoclax or HMA venetoclax in that retrospective analysis. So the bottom line is, if your patient falls into a favorable risk group, those with NPM1 mutation or those with IDH1/2 mutation, and maintains a good response, there's a fairly good chance you stop the therapy and they can maintain a good response for a longer period of time. And there's also evaluation of using 7+7 regimen, right? Right now, the standard of care here is to do continuous regimen, but we hardly anyone do continuous venetoclax here due to myelosuppression cytotoxicity. We usually tend to stop at day 21 in healthy individuals once the blasts are cleared and do a bone marrow biopsy and then subsequent cycle based on count recovery. But there's a 7+7 regimen that has shown to achieve a comparable response rate after second cycle, not after first cycle. In that group of patients, the median survival was comparable overall, around 12.6 months compared to 14.5 or 15 months from the VLA long-term data.
Thank you.
Conditioning period. You had the question about conditioning regimen?
Dr. Talha, there's a question that what is the optimum conditioning regimen in a young fit patient with AML?
Well, the optimal conditioning regimen still stays the myeloablative conditioning regimen shows to have a better relapse-free or even free survival. However, it's become challenging in elderly patient population where they have seen high mortality. So I think I'm not a transplant physician. As a disclaimer, I treat leukemia. I refer patients to our colleagues, but I think the myeloablative conditioning regimen is still the best way to go forward for healthy young individuals with SCTCI score less than 3 or so.
Yes, that would make sense, of course, because we know that intensity of treatment and conditioning about the FB4 versus, so this was particularly in regarding the FB4 regimen versus the versus BUSI, and of course the general impression would be, and I think the consensus overall is that intensity of the conditioning would impact the long-term outcome, and for younger patients, BUSI would probably be preferred. Yes, yes. Yes, 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 exactly.
I also want to have a comment regarding the Dr. Shahrukh talk on CAR-T therapy. The mic, I don't know, Dr. Shahrukh is, but he was given some of the things, but I mean to say that I've gone through the Indian CAR-T therapies centers, and one of the center in the Bangalore, and I've come to know that the cost of the CAR-T therapy in Bangalore, which is just, it should be quite similar to our setup, but the cost is down to about $120,000, just preparation, and not the other package of that, just preparation of the CAR-T therapy is $120,000. It is round about, I think, 3.5 crore Pakistani rupees. So I don't know, Dr. Tariq and Dr. I think Qamar Nisa Chaudhry is in a better position. How much it will cost in Pakistan?
So that's a very good question. That's a very good question, sir.
Equivalent to, but it should be less than that, I think.
I think $1,000.
$120,000.
Sir, if we just give an overview, so if even we go to a fully automated like Miltani, the cost would be, so it would be around $40,000 to $50,000.
Here, Pakistan?
Yes. If we move to semi-automated, it would be around $25,000. And we are looking at avenues to even reduce it to less than $25,000. So let's see, inshallah, sir, how the
So
things
it's
go.
very cheap from that point of view.
Sir.
Yeah.
I think that's one of the areas where you could have more health tourism, perhaps. And definitely, I think the cost will come down.
Because in India there are three types of they are preparing. One is this is the autologous. The second is allogenic. They're donor available, and the third they are using that is even more than that cost, and that is off the shelf. That is that is a ready-made preparation, which costs you round about $150,000 off the shelf. And they are purchasing it from Spain, this off the shelf.
So I think
Dr.
it's a
Irum
great
Khan is
session.
online with us. Dr. Irum, would you like to make any comment?
Yes, please.
On the subject of CAR T cell, I don't really have anything to add. I would just echo what Dr. Badar said about, the fact that there's a lot of work going on into modifying the approaches to AML treatment. And I think some of those, especially the shortening of the duration, is probably quite relevant to resource-constrained settings, in terms of limiting the duration of exposure and also then the supportive care and infectious complications. Thank you.
Thank you so much. Thank you, Dr. Irum, Dr. Talha, thank you so much. Dr. Shahrukh, thank you so much for being with us in spite of the time difference zone. And with this, I would close the session. We move on to our next session.
Thank you so much.
Can we have the moderator, please? Thank you.